সাউন্ড একটু অফ করুন। মিটিং চলছে এখন একটা মাস। হ্যাঁ, ওয়াইফাই চলবে তো?
ওয়াইফাই চলছে না, ক্লাসে ট্রেনে আপনি জিওর ওয়াইফাই পাবেন 1 GB।
জিও
ওয়াইফাই জিবি সারাদিন।
ওয়াইফাই লাগবে আমার, ওয়াইফাই দিতে পারবে না? পারবে। হ্যাঁ, আমি জিজ্ঞেস করে আরে আমাকে বলেছে বলে তো, নাহলে আমি আসতামই না, ওয়াইফাই করে দিতাম।
So, how many students we are expecting to participate in this?
Somadip?
Sir, I think there will be 30 to 40 at least.
Okay.
So, and it will be in the YouTube channel also. So,
Okay.
the rest of all who are doing duties now, they can see later in the YouTube also.
Okay, nice, very nice. It's a good initiative.
Yeah, we have already started this for the last couple of months, 2-3 months. We're
Okay.
planning to take it further in every joint. We have a discussion in bone tumor 2 weeks ago. So every part would be covered, because because in different parts students is difficult to communicate. So online platform is a good area, so that this can participate, can discuss. And COVID has learned is a positive side of COVID.
Yeah.
জুমে চলবে? জুমে চলবে, জুম অন হবে? দাদা, ওটাতে হয়ে যাবে। এটা অন করবেন।
নিজস্ব মোবাইল নাম্বারটা মারতে হবে।
হ্যাঁ,
ওটিপিটা এই করলেই পরে
এটা
জিও প্রাইভেট নেট, এটা
জিও নেট।
So we can start discussing about CTV. In the meantime, video will be loaded.
Hello. Actually, is there anybody ready to tell about the diagnosis?
It shall ask Dibangshu. Hello, Dibangshu.
OTP আর মোবাইল।
Is there any other PGT is ready to get the diagnosis?
Shivashish.
Yes, sir.
Who was the first presenter?
Yes, sir.
Who is going to present the case? The first student?
Sir, 1 second.
Who is going to present?
Sir, Abhishek Mullik.
So, Abhishek, please start with your come in front.
It is better if we can see the case also at the same time.
Yes.
Sir, I'm almost there, sir. Video is there. Just for 30 seconds more.
Okay. How much time will it take?
Sir, 30 seconds. 30 seconds more.
30 seconds.
টিভিটা আসছে না কিন্তু আসেনি।
আমার তো ওয়াইফাইতে একটা চলছে মিটিং।
Okay, Somadeep sir, please allow me for screen sharing.
You share the screen. It's not allowed. You share your screen.
It's been allowed now.
It's been allowed. Just start sharing.
ওয়াইফাই আসছে না, ওয়াইফাইতে ওটিপি আসছে মোবাইলে, এইটা মারলে পরে কানেক্ট হয়ে যাবে ওইখানকার ওই
ওইটা কত
এবার আসবে।
You share your screen, Dibbangshu.
sir.
So what is your name?
Bangshu, please start. Abhishek.
We have discussed a lot about.
What's problem? Bangshu?
sir, Richie sir, accent. আমার স্ক্রিন দেখা যাচ্ছে স্যার?
No, it's not been shared.
We can see you, but not the screen.
Shared screen, green option. You can see the
না এটা তো হ্যাঁ ঠিক আছে হ্যাঁ এটা একটু বড়
দেখা যাচ্ছে?
Yes. Make it now it's okay. It's okay.
Is it visible now?
Yeah, make the full screen. Make it full screen.
এটা দিয়ে না এটা তো আমার
That's okay.
Is it visible?
Yes, it's visible.
Okay, the main video which is being actually that is of 45 minutes. I'm making that video. I'll take few times. These are the two other cases which will be shown now.
না এটা তো মোবাইলে লেতে চলছে ভালো।
I'm starting it, okay?
মোবাইলে হবে না?
হ্যাঁ করা যাবে হ্যাঁ কিন্তু মোবাইলে সেটা তাহলে
এটা যদি ভালো আসে তুমি এটার সঙ্গে কানেক্ট করো,
এটার সঙ্গে কানেক্ট করবো।
হ্যাঁ হটস্পট অন করো। নাহলে আমার কাছে ছোট ইয়ে আছে।
Who is presenting the case? Please tell the PGT to tell the diagnosis and everything. Who is presenting the case?
মানে এটার বেটার ব্যাটারি আর ওটার ব্যাটারি এটাকে
Abhishek or who is presenting?
করে দিচ্ছে।
This is the case of Shivashish, I think. Shivashish?
Yes, sir.
Yes, you start presenting the case.
You tell me
Professor
what
Pal
is
has
your
said.
diagnosis? What is your diagnosis? Dibangshu, you stop the video here, make it still, and show
patient is there, so
it is not at all audible.
We want to see the fit.
Yes. You sure? Yes. Now, Shivashish, what is your diagnosis?
Sir, this is a case of bilateral syndromic CTV in a 1.5-year-old child currently undergoing standard corrective treatment associated with arthrogryposis multiplex congenita.
okay, fine. So, what are the points in favor of your diagnosis? Why you are telling it is a CTV? One thing I just telling to all the students, please don't use any abbreviations in the examination. Okay.
Okay.
It's very annoying to the examiner. So always use your complete word. It is a congenital talipes equinovarus. Whatever time may be required, we should use the complete term. Is it it? Okay. So what are the points in favor of your congenital talipes equinovarus? Please answer the question.
Sir, it is congenital because it is present since birth.
Okay.
And there is it involving the talus, and that is the ankle and foot, that is talus. There is equinovarus deformity at the ankle and varus deformity in the hind foot, and the whole foot is look like a bat or club shaped. So it is a club foot or congenital talipes equinovarus. And in the joints, there are stiffness of the joint. The limbs are cylindrical. And
Can you just wait? Can you just wait?
okay, sir.
I think you have jungle up everything. The question was why it is a congenital talipes equinovarus. So it is, you said it is since birth, okay. Talipes equinovarus. You should tell the components. You are jumping at stiffness of the joint. You are telling us talus and ankle. You are telling us talus and tibia, something like that. So congenital talipes equinovarus. So what is the composite diagnosis, your clinical composite diagnosis?
Sir, there is the compositions are cavus, adduction of forefoot, varus of hind foot, and equinus at the ankle joint.
Fine. I think that
But I think this is with clarification. So for the basic third year student, I think this is okay, but just adduction of forefoot is not sufficient enough for passing in the MS orthopedic examination.
At the mid-tarsal joint,
Yes, we have to tell the every deformity at occurred at each joint. This is extremely important. Please tell again.
sir, cavus occurring in the longitudinal arch of the foot, adduction of the forefoot at mid-tarsal joint, varus of hind foot, which is mainly occur in the subtalar joint, and equinus at the ankle joint, that is the tibiotalar joint.
Now it is almost complete now. Now why it is cavus? Is it the usual component of CTG or is it a secondary component?
Sir, it is the exaggeration of the longitudinal arch of foot. Actually, it is contributed by many joints, mainly manifested by dropping of the first metatarsal head.
Why? Why there is dropping of metal? Is it a paralytic one, or is it some soft tissue teaser, or some bony deformity? Why there is a drop of the first metatarsal?
Sorry, sir.
Okay, Dr. Borua, please continue your question.
Yeah. So you have told us that
Hello.
Yes.
The question is not clearly audible, sir.
So the question was being raised, the keywords. From that, can you hear me? Can you hear me?
Yes, sir. Hello.
Hello, Dr. Borua is not audible.
So one is, can you hear me? Just a moment. Can you hear me?
Namadev sir, বলছি the main video is ready.
No. Can you hear me now?
Yes, sir. Yes, sir. Please.
Hello.
Yes, you are audible, sir. Please.
Can you hear me now?
Yes, sir. Yes, sir. Yes.
Yes, audible, sir.
Yes, you are audible.
Hello.
Yes, sir. Please continue.
Can you hear me now?
Yes, sir.
Yes, you are audible, sir. You please continue.
Neither I can hear you.
Yes, sir, you are audible. Please continue.
What is happening?
Please ask questions.
Can you hear me?
Yes, sir. We can hear you.
Okay. Can you hear me now?
Yes, yes.
Yes, yes, sir. You are audible, sir.
Can you hear me now?
Yes, yes. Yes, sir.
Hello?
Yes, sir. We can hear you.
Can you hear me now? There's no response from your end. Can you hear me now?
Yes, 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 sir.
Yes, sir. Yes, sir.
Hello?
Audible,
You're
audible.
Amarnath Chatterjee, can you hear me now?
Yes, sir. You are audible, sir.
Acha, okay. Okay. So you said about the kevas and you said about you missed something. Did you say about something else in the 4 foot?
Sir,
Hello?
hello.
Yes.
Am I audible?
Yes,
There
sir.
is adduction of the forefoot at
Am I
mid-tarsal joint.
audible? Am I audible?
Yes, sir. Yes, sir.
Okay. I'm not getting back you.
Yes,
I'm
yes,
not
sir.
listening. Your sound is not there.
Yeah, you are audible, sir.
Vibhanshu or whoever is presenting.
Actually, I've given the answer. Actually, the capacity is because of
Vibhanshu to everyone. Kindly go to mute the tab. Hello.
yes, yes, sir.
Hello. Hello.
Hello, we can hear you.
Hello.
Hello.
Very good. You can hear me? Can
Yes,
you hear me?
yes, sir. Yes.
But I can't hear. Your voice I can't hear. I can't hear you.
Yes, sir. We can hear you. Please tell, please, whatever you question, please tell. Okay, problem.
Sir, then once you please, log out from your Zoom account and again you log in, sir. It will be, I think there's some glitch going on through your system.
Please write it in your chat box because we cannot hear us.
Oh, yes, yes.
Write it on your chat box. In the meantime, what I just
Sir, in the meantime, can we start the next case? It's actually the main, video which being shot.
Still, I'm giving the answer because these are the questions we will ask in the examination. Because actually, this is the basically PAVAS. Initially, it was not considered as a primary deformity, but now it is considered as a primary component of the CTEV, and basically it is due to the relative pronation. Pronation of the forefoot, where the hind foot is relatively supinated. So basically, there is a break of the foot at the mid-tarsal joint. Now the question is, can anybody tell Devanshu, which joint is maximally at fault at CTEV?
So this is Shivashi. This is Shivashi's presenting, sir.
Okay, anybody, please answer. Anybody, please answer.
Sir, your question, please, sir.
question is, I have already told there is a relative pronation of the forefoot in respect to relative supination of the hindfoot at the level of the mid-tarsal joint. The foot breaks at the mid-tarsal joint. Now there are several mid-tarsal joints. Now which mid-tarsal joint is maximally important for the foot breaking? Can anybody tell? Because that
Sir,
is the most.
Sir, the talonavicular joint and the calcaneocuboid joints.
Exactly. So this is a talocalcaneonavicular joint that is basically known as the acetabulum of the forefoot. Acetabulum of the foot. As the hip joint actually. It's a face acetabulum. It is known as the face acetabulum. So basically it's a ball and socket joint. Ball is produced by the talus, and the socket is produced by the naviculocalcaneum. Okay. So this is the face acetabular area. That is the foot breakage occurs. Now we have told it is a syndromic clubfoot. What are the points in favor of syndromic clubfoot? Can anybody tell?
Sir, it is syndromic because it is associated with the congenital abnormality, that is arthrogryposis multiplex congenita.
Just a minute. Dr. Ranjit Buru has having some problems. Can anybody please communicate with him over the telephone? Can anybody please communicate? Somadip, are
Yes,
you
sir.
here?
Yes, sir. I'm trying to call, sir. Borua,
Yes.
sir.
Communicate with the Ranjit Barua so that he can
Okay.
join, can log out and join. Okay. And once he has succeeded, please inform us. In the meantime, we will our program. Okay.
Okay, sir. In the meantime, you continue. I'm contacting Professor Buru.
Okay. So next question is what are the points in favor of syndromic clubfoot mentioned? Please.
Oh, I can't log out since you are sharing your screen. No, I can't find my screen there.
Yes. Carry out.
Yeah.
Please answer the question now.
I cannot hear your voice. There is a problem. I cannot hear your voice. Tell him to log out, then we log in again. I think that will be better.
Sitanshu, please answer the question. Points in favor of syndromic clubfoot.
Sir, there is stiffness of the joint, cylindrical appearance of the lower limbs, bilateral lower limbs.
Stiffness
And
of
there
which?
extra pad of fat in the sole.
No. Is there any
One thing, Anando, I want to interfere actually. That
Yes,
is it is arthrogryposis that is syndromic. That means some associated other features which is present congenitally. Now, arthrogryposis, the main feature of arthrogryposis multiplex congenita is stiffness. There is a paucity of joint movement. That is the stiffness. That
Can you hear me now?
Yes, sir.
Cylindrical limbs is a relative finding. It is later on. That is the less bulk and paucity
Can you
of
hear me
the
now?
joint creases.
Sir,
That
yes,
is
sir.
the very important thing. That is the number one is stiffness. Number two, less muscle bulk. Number three, paucity of the joint creases. These are the very important thing. And lastly, that is as because the bulk is short, bulk is not there. So it looks like cylindrical. Muscle bulk is not there. So it looks like cylindrical. The first thing is stiffness. Number two, paucity of the joint creases. And next, this is one of the associated feature is that is a foot and ankle may be associated. That is a syndromic clubfoot. It associated with these features. It may be other syndrome, but here this case is of after you can see the hands. That is the upper limbs. These are stiff, and there is a paucity of the joint creases, and that there is a less muscle bulk. This I think this should be the answer. Only the cylindrical limbs is not the answer. That is a stiffness and paucity of the joint creases. That the stiffness is the feature of this stiffness of other joints is the feature of arthrogryposis.
Absolutely, you are right. But I want to some confusion. He said syndromic clubfoot means what? That means the clubfoot plus syndrome, isn't it? But
Yes.
there are some telltale signs of syndromic clubfoot in the foot also. Okay. So actually, I wanted to know, is there any clinical clue in the foot which can suggest that it is different from other idiopathic or any some biogenic or neurogenic club? So that is my question. And the picture you have shown, there is a clear hint. There is absolutely clear hint that there is a possibility of that is syndromic clubfoot. So what is that? That is the great toe. So that there is a just 3 or 4 months back, there was a classical lecture was taken by that is Matthew Varghese sir. He has clearly pointed out, see the great toe. The great toe is completely downward. So this is the actual not commonly seen in any normal clubfoot. So this is the sign. That means if there is a significant contracture also in the great toe as also the toes also. So that is the most important feature of the clue that this is not a normal clubfoot or idiopathic type of clubfoot. That is the possibility of the syndrome. Now the question is, which syndrome?
No, Anando, can I make a point here? That is the feature. That is a great toe is one of the very important feature. That is, it is short and it is dorsiflex. This is the most important for the atypical clubfoot. Syndromic clubfoot is a different entity, but it is, I think we are mixing up. That is an atypical clubfoot. The great toe is short and it is dorsiflex, usually. And in syndromic clubfoot, it is an atypical clubfoot. And syndromic clubfoot, it may be arthrogryposis, it may be some that is different issues. But this that is you are talking about, I think, atypical clubfoot. That is, it is again an entity. That is, one is idiopathic, one is atypical, and another is syndromic.
Yeah. But in this atypical and syndromic, there are some questions, some features are almost mixable. That is why I'm telling. And if you see, I think I have not examined the toes. If the movement of the great toes is already reduced, usually in normal clubfoot, this is not the usual case. But if it is a syndromic, as the stiffness we have told about, that stiffness is also invaded in the toe joints also. That may be the feature of the syndrome. That is I want to inform. You understand what do I mean? So this is the one of the clinical clue of the foot. Now the question is, what are the syndrome? Now this is the arthrogryposis, and basically you have already rightly mentioned, it's a shapeless cylindrical limb with multiple joint contracture. And now that another question will come, the arthrogryposis. There may be central type of arthrogryposis, or there is peripheral type of arthrogryposis, or there is some mixed type of arthrogryposis. Now the next question will be, if it is arthrogryposis, now which type of arthrogryposis is there? Is it a central type, or is it a peripheral type, or is it a mixed variety? Now that's the question. Please answer this. Central means what? Central means that the axial joints mainly affected, but peripheral joints are not affected. Very simple. It is a peripheral type, means the limb joints are mainly affected. Central joints, basically the neck, axial joints, that means the hip, trunk joints are not affected. As a mixed variety, generalized variety, then both the axial and the peripheral joints are affected. Okay? Which type of arthrogryposis it is? Depending on that, peripheral arthrogryposis has a relatively better prognostic indicator. As it is going to other types, there's less bad prognostic.
So it is a peripheral one.
Okay, very good, very good. Okay, so it is a peripheral type of arthrogryposis, isn't it? Okay. Now the question is, so have you met the clinical types of CTV? Which type of clinical types of CTV? Depending on the treatment, it may be untreated or
Sir,
it may be, yeah.
It is actually undergoing treatment at present.
What is the age of the patient?
Age is 1.5 years.
Okay, okay, okay.
You have, can I ask one question?
Yes, sir, please, sir, please.
Yeah.
Yes,
So actually now my, the audio has come back. I don't know what happened.
sir, please, sir.
So I missed in between almost 10-15 minutes. So just to recapitulate, at what age you received the patient, this patient?
That the age of the patient is 1.5 years.
And since when you are treating this patient?
He is receiving the treatment from last 1 year, from the age of 6 months.
Okay. So what treatment you are giving to him?
জল হবে জল জল
Standard Ponseti technique, conservative method.
Last 1 year.
Yes, sir.
Okay. So how long you will continue this Ponseti? How long? You will continue for next 2-3 years or something like that? So basically, I think this is a rigid type of clubfoot, CTV. So at some point of time, like standard CTV, you need to go and do some surgery maybe later on or in relapse cases. But do you think that this patient may require some surgery at this stage to cut short the period of your immobilization and then make his foot more better looking so that he can start normal ambulation?
Sir, in this age group, soft tissue release can be done.
No, Adi, what is the idea of treating this patient? What is your idea of treating this patient? Why you want to treat this patient?
Sir, to give him a functional plantigrade food, which is cosmetically better and functionally acceptable.
Okay. The second point is you want to continue this. So what is the stage now? At what stage is? What is his scoring system, Pirani score, or whatever it is? That how much of the equinus has been corrected? What is the inversion has been corrected? How much of the adduction has been corrected? Anything you can highlight on?
Very less amount of progress since the start of Ponseti casing. Previously, it was when I was started the casing, it was around 5 and 5.5 in one leg, another leg. Now it is 3.5 and 4 in the two legs.
In over a period of what time?
Over a period of almost 1 year.
Okay. Kevas has been corrected?
Sir, Kevas has been corrected.
There
is some sagging of the head of the first metatarsal again.
No.
Reappearing.
No. Kevas, when it is fully corrected, how will you know that Kevas has fully been corrected? It can come back. Moment you leave the foot, it can come back. But how do you know that that deformity has been corrected? You get my point.
Yes, sir.
Kevas is a drop of the first metatarsal associated with what? Supination or pronation? Forefoot.
Sir, pronation of the forefoot.
Forefoot. You need to see that pronation is corrected. At the same time, then only you can correct the Kevas. That is why the first two in normal CTV case, you need to correct the pronation at the same time. Once you try to correct the pronation, Kevas is going to be corrected almost automatically. Is it okay, Anand Kishore?
Yes, sir. Yes.
Yeah. So I think it is not that it takes longer time. So you try to correct Kevas some point of time. You try to correct the inversion to some point of time. I think you should go step by step. Even it is a syndromic. Try to correct the Kevas first. Bring the foot into supination, forefoot in supination to the hind foot supination. And then you start doing the abduction slowly, if it is possible. And then, so you are taking more time over a period of time. So if you continue like this, manipulating all the time, there'll be fibrosis of the soft tissues. You'll be putting more force onto this. So you need to correct. Maybe you can resort to some early surgery so that you cut short the recovery time for this patient and then try to do any other things. So your aim is to make it plantigrade as early as possible.
Yes, sir.
And for that, you need to correct. You may not be able to correct the that can be maybe by doing a part, but then pronation of the foot speaker abduction. I don't know, we are doing protocol of doing this. I better in 1 year. So I 6 it is 3.5 score. Oh, right. Hello.
Yes, sir. Yes, sir. Your voice is actually cracking, sir. That is the problem.
In this type of scenario, I think we have to modify this paucity, which is known as modified method. That is, we have to go for early tenotomy, that is to reduce the equinus, and also we might have to go for a Steiner fasciotomy. That is, sometimes it is not possible to have the correction by only conservative means. That is means by plastering manipulation. Actually, this patient has underwent this. This fasciotomy, Steiner, and also this is in very selective cases, not in every case, that's because the creams get corrected by serial plastering, and it is a difficult scenario. It's an absolutely different scenario. I actually kept this as a second case, not a first case. That is a typical case. He has not posted here. That is it is a difficult case, and even we cannot achieve this full dorsiflexion in this type of foot. We might have, that is a bit 10 degree or 5 degree equinus, fixed equinus deformity, or some amount of cavus. But even 70 degree abduction of the foot is not possible. We even in 40 degree abduction, we have to go for this. That is the orthosis. We have to go for orthosis. And it gets gradually corrected, but we have to keep this type of patient under close observation. That is that it might need some, again, plastering or repeat operations. It is absolutely a different scenario. It is usually not being asked in the examination. Actually, they have put this case, the second case, as the first case. That's a difficulty. That is, it is not the normal scenario during examination.
Absolutely.
I think
Professor Wboa.
Yeah.
Yes.
I think this case needs a very holistic approach.
Yes.
It's not only the lower limb. You need to do the upper limbs as well. Yeah.
Actually,
Absolutely.
it's totally a different scenario.
Yeah.
Okay, please, sir. Okay, thank you, Devdatta. Can you go to the second case?
Yeah. I think we should have some normal CTV
yes,
type of case.
I'm posting it, sir, the normal one.
Yes, you please, Dibanshu, please give the first case.
Yes, sir. Running it.
I think the discussion on the first case led to some observations. That is, the PG should take it into consideration and study in that line. It is not that it will not come in the exam, but for your academics and other things, you must see what questions were raised, how to proceed to this case.
Yes.
The role of early surgery in this type of cases. It's a rigid type of foot. If we ask you, is a flexible or rigid? It's a rigid type of foot, and it is a secondary type of foot. So it needs early surgery. And you cannot just keep on manipulating. There will be a lot of soft tissue injury and other things. Okay, we go to the next case.
So is this video visible?
No.
Yes.
No.
I can't see.
It's visible. Only screen is visible.
Video is not visible?
No.
Let's see.
Sometimes this internet becomes very unstable. What happened again?
Nothing, sir. I'm just sharing the video. Is the video visible now?
Yes, yes.
Yes, yes.
Okay. I'm playing it up.
I think as in the beginning, Anand Krishi told you in a short case, you need to. Can you hear me?
Yes, yes.
Yeah. So at the beginning, it was told that you should tell the diagnosis. When you tell the diagnosis, it's very important that you tell it in such a way that treatment is well established.
Exactly. Please
So is
start
the
with
audio visible? Audio audible? I mean the of the video.
No, no.
No. Audio is not visible.
It's not required. Please tell your diagnosis.
Abhishek, tell the diagnosis.
Sir, this is a case of idiopathic. This is a case of left-sided idiopathic congenital talipes equinovarus. In a 4-month aged male child who is undergoing treatment without any neurological disease.
So you have finished your diagnosis? Have you finished your, diagnosis?
Yes, sir.
Hello?
Yes,
Yes?
sir.
Okay. You started with left-sided. I don't think you should start with left-sided. You should always tell that this is an idiopathic talipes equinovarus unilateral involving the left side in a 4-month-old boy undergoing treatment in our institute. So don't say left side, because what we want is that what is the deformity the patient has come to us for treatment. It is a CTV, like cubitus varus. You don't say that it's a malunited supracondylar fracture leading to cubitus varus. You always start with cubitus varus due to malunited supracondylar fracture in a blah, 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 like that. Similarly, in CTB, you start with is a congenital, idiopathic, talipes equinovarus involving the left side in a 4-month-old boy undergoing Ponseti treatment in our institute. Then you can also add what is the Pirani score at this point of time. Then we will know that how much more treatment is required, number one. And number two, at what time you started your treatment. Undergoing treatment since when? That is also very important. And secondly, that Pirani score at today is this. So that we know that whether your treatment is going on smoothly or not. This will also give us another insight to decide our treatment. Is it okay, sir? Deva Doctor, sir?
Yes, yes, sir.
Mhm.
Yes, sir.
Absolutely.
Actually, I should say that is you are absolutely right. It's a congenital, left-sided congenital. It's hears very badly. That is, it is like in Bengali. That is a sonar kaner dul, kaner sonar dul. Our ear is not in Bengali. We should say it kaner sonar dul, not sonar kaner dul. Our ear is not made of gold. It is like the left-sided congenital. In every class, I ask them, don't tell like this. You say this is a congenital talipes equinovarus that you have said, and also give the Pirani score. It will give us an idea about the deformity. Everything.
And since when you have started the treatment?
Yes,
This is
yes.
very important.
But I don't know why they are missing. That is a discredit of mine, actually.
No, sir. Nothing like that. Sabko hota hai.
No. It is a total discredit of mine. They are not actually. You see.
No.
Okay. Since when the treatment started?
The treatment started since the baby was 2 weeks of
আসার কথা কিন্তু সবাই বেরিয়ে
2
পড়েছে।
weeks. 2 weeks. Okay. Now, can you tell us why you have said it is a congenital, why it is a talipes equinovarus? Can you just tell us?
So it is congenital because it is present since birth, and
Yeah.
this talipes the talipes means it is the two terms.
No. Don't tell us what is telos, what is pes. You just tell us Means where are the deformities? What are the deformities in fact?
Deformities in the ankle joint, the tibio-talar joint. There are 4 deformities, that is cave deformity.
Do you start with tibio-talar joint first, or start with the forefoot? How do you start in CTV? Yes,
Forefoot adduction.
forefoot
So there-
adduction.
There are forefoot adduction.
Oh.
There
Do you
is,
start with forefoot adduction, or you start with something else?
actually it composes of 4 deformities, cave deformity. Cavus, adduction,
No,
varus, and
sir, what is sir asking? What is the main culprit of this? You have already said. You have crammed the mnemonics, but you are not telling it. What is the most important? That is a culprit of congenital. What sir is asking? You answer it.
We have started with this discussion with this just before 10-15 minutes back.
So you should start with what? Should you go to the hind foot or start with the forefoot? And when you start with the forefoot, what is the most important? Which you correct first in your treatment? Kevas. And I think in the kevas, you should also mention that there are 2 components in the basically 3 components, but most important is the kevas. And this kevas is due to forefoot pronation. This is very important. That is why in the first stage in your treatment, you correct the forefoot pronation to make the foot supine. The forefoot supinely aligned with the hind foot. You understand? So forefoot kevas because of the drop of the first metatarsal with pronation, something like that, and then adduction, and then there is an inversion in the subtalar joint, and there is a flexion, plantar flexion at the ankle joint. Okay. Next is you understand now?
Yes, sir.
Can you repeat your diagnosis?
Sir, my diagnosis is congenital idiopathic talipes equinovarus, unilateral case involving mainly the leg, involving the leg in a 4-month aged male child with PRS score 2.5, who is undergoing treatment in our hospital
Since
2 weeks of age.
Since
2 weeks of age.
Oh, okay. The next question is we ask you that yes, okay. You tell us the deformity. Can you again repeat it?
There is deformities, cavus deformity, adduction deformity.
No. Kevas where? Where is the kevas?
Forefoot.
There's a kevas. There's a kevas of the forefoot with forefoot gone into pronation, right? Then next comes your even forefoot adduction.
Forefoot adduction, then hindfoot, and
no, subtalar joint. You did not tell about subtalar joint. What is there in the subtalar joint? What is varus? What is varus?
The calcaneum undergoes varus deformity.
Okay. Why do you say it is idiopathic?
On clinical examination, I didn't found any other associated abnormalities in this baby. From inspected from head to toe, from back and from front, and from back I cannot find any abnormal
Okay, just wait. Since it is an idiopathic, there may be a secondary congenital type also, right? Yes. So for descriptive purpose, can you just tell us how do you classify the congenital secondary Talipes equinovarus? Congenital secondary Talipes equinovarus classify. You know it? Do you know it? Hello? There's a lot of disturbance. I don't know. Can you tell us those things? Classification of congenital secondary Talipes equinovarus. Can you hear me? Do you know it?
So if it is isolated syndrome,
I can't hear you. Can't hear you.
hello, sir.
Yeah.
Hello.
Yeah, tell me.
So if it is associated with another syndrome, syndromes, then it is secondary situation.
You see, syndromic will come later on, but you should classify this as a muscular, osseous, and neurogenic. Okay. Osseous is where there is an absence of, for example, absence of distal end of the tibia, medial side. Muscular, you can tell it is a multiplex arthrogryposis, multiplex congenita. Neurological, you can say cerebral palsy, Frederick's ataxia, and then you should look into the ciliary fissures of those conditions. Since those are absent, you can tell that this is a primary idiopathic primary CTB, right? Okay. Have you examined apart from the systems? Have you examined some special sites for this baby after examining the foot?
Sir, I have examined the upper chest and abdomen, upper limbs also. In the upper trunk, sir, I have examined if there is any low posterior hairline or there is deformity in the neck, short neck, or there's any deformity in the shoulder joint. And I have also examined if there's any deformity in the hands.
Before ऊपर में और क्या मिलेगा आपको? एक तो क्लेप पैलेट, ज्यादा देखना नहीं, क्लेप पैलेट. You come down to heart, you can go for upper limb, go to heart, auscultate if there is a murmur, come down to the hip if there is a CDH, and look into the spine if there is a spina bifida, and if the male child, go for the testis, whether it is in normal position or there's a retracted testis. I think these few parts to be examined and then rule out any other congenital defect. There are two things, don't get confused. One is associated congenital defect. Another is a syndromic sort of associated diseases, where CTB is a part of it. If there is a heart disease, some VSD or something like that, it may not be associated with your CTB directly, but it is a part of congenital defects. So you should differentiate syndromic and all this. Cleft palate, it may not be syndromic. You understand?
Yes.
So this examination is very important to prognosticate. For example, the child has got a heart disease and the child needs some manipulation under GA or some surgery under GA. You cannot do it until and unless your heart is taken care of. So it will be delayed. The child foot will be remaining in deformed foot for a long period of time, where the treatment will also be prolonged. So cleft palate. Secondly, thirdly is your heart. Then the hip joint, spina bifida. If it's a male, you look for testicle. I think these points you should not miss. If I come for your examination, I'll ask you. Okay, go ahead. Anything you want to add on this? You just, when you just describe the food now, can you describe the food? Can you describe the food? You see, CTB, you see, is that before telling the CTB what examination of the food, you should tell us. It's not only the deformity, associated deformity, you have got another findings. What are these? The foot is small or it is same size of the opposite side. The lateral border is longer than the medial border, right?
Yes, sir.
The foot are splayed, they're spreading in the front. Then of course, you should tell us that there is an wasting of the calf muscle or not. Deformities can be corrected. If it is a newborn child, deformity is correctable or not. You'll have to differentiate whether it is a rigid type or is a flexible type. Even at 3 months' time, you may not be able to correct all the deformities. But then the foot is supple, you can mobilize some of the joints. So it is not a rigid, it is a flexible type of CTV. So this point is very important. And then when you feel that you cannot move the foot joints, different joints, automatically it comes that it is a rigid foot. Then you look for the causes of rigid foot, neurological, muscular, and those things will come into discussion. If you look into the foot, what I can see here, there's a splaying. The forepart of the foot is, and the pronation is very prominent in this case. Pronation of the forefoot is very prominent. And then the lateral border will be longer than the medial border. Okay. Yeah, any other things? Chatterjee sir, any other things?
No, you're right.
Mhm.
Actually, the patient, it is not the foot. Actually, you have to see from the face to the, that is the what you have said rightly. That is that you have to see the heart and even the other joint. That is that it may be a part of the syndrome. That is the knee may be dislocated congenitally, the hip may be dislocated. That is the type of Larsen or face. And if there is a meningocele or meningomyelocele, it may be a dangerous to put the patient under general anesthesia. And it may lead to different type of problems in meningocele or meningomyelocele or in the like that is Pierre-Robin. That is a different, it is a rare syndromic type. But you have to see the patient, they have to see the patient as a whole. Otherwise, they will miss a lot. And the thing is that is the first thing one should not miss. Actually, it should be renamed. The Talipes equinovarus. I should say that is a Talipes, congenital Talipes cavo equinovarus. I should think that it should be renamed. That is, thereby they will not miss the cavus.
Now, why do you say there is a cavus?
Sir, because there is exerted medial arch.
Longitudinal arch or medial arch?
Medial arch.
What do you mean by medial arch? I know a arch called transverse arch, and I know a longitudinal arch. Of course, it can be longitudinal arch. Yeah, there's an increased longitudinal arch.
That is the
At the same time, there is an associated. Always remember, never ever in CTB treatment you try to pronate the foot. You try to hold the calcaneum. Never. That is why I'm stretching on this forefoot pronation all the time. You understand? Once you correct the forefoot pronation, your cavus is going to be corrected because you are making the forefoot supination along with the mid and the hind foot. Okay, this is cavus. So, what else? How do you know that there is an inversion of the subtalar joint? Clinically,
If we look from behind, we can see that the calcaneum is rotating medially.
you see the calcaneum. Do you see the calcaneum in clinical examination?
Actually, the heel is vastly rotated medially.
If you say rotated medially, I think sometimes you can be missing. Why not? That the sole of the foot, the whole sole of the foot is looking medially. That is I think that is should be the important message. Rotation, okay, is rotated and facing medially, right? How do you know there is an equinus? How do you see, look for equinus? How do you see from? How do you hold the foot or the leg or what?
So if we hold the in maximum corrected position, the dorsum of the foot touches, actually the dorsum of it easily touches the shin of the tibia, of the distal leg. If it is less than 90, the angle between the foot and the distal tibia is less than 90 degrees, then it's risk of equinus deformity. Actually, it goes beyond 90 degrees. Hello.
Yeah, you should see from the side.
What's the next?
You should see from the side, keeping the knee straight, and look for how much equinus is there. Right?
Yes, sir.
See from the side, holding the leg, making the knee straight if is possible, and see how much equinus is there. Okay. Now you said about creases, right? Medial crease. Yes. In the medial crease, there is a posterior crease, right?
Yes, sir.
And accordingly, you in Pirani score 0, 0.5 and 1 you make it. So what's the, do you get normal creases on these areas?
Yes, sir. Normally, you can get
How do you differentiate between a normal crease and an abnormal crease?
in case of CTA, we can find there is single deep crease. But normally there will be a multiple fine creases.
Okay. Why these creases are formed?
So the creases are the posterior crease is formed because of the equinus deformity. And medial
I mean, why in general a crease is formed?